Hello friends, let us continue our lecture on Parkinson's disease. Till now we have completed the etiology, clinical features and diagnosis of Parkinson's disease. In the treatment aspect, I have completed the levodopa therapy and also dopamine agonists. Now I would like to discuss about the other drugs which can be given for Parkinsonism. One such drug is monoamine oxidase B inhibitor. So monoamine oxidase B inhibitor. How does this act? There is levodopa, right? This goes into the blood-brain barrier. So this levodopa, which has gone into the blood-brain barrier, it is converted to dopamine. Just a minute, sorry, I don't want to go all through this. So what does monoamine oxidase B do? Monoamine oxidase B is an enzyme which is involved in dopamine metabolism. Dopamine can be converted, is metabolized by two enzymes. One is monoamine B, oxidase B, and it forms 3,4-dihydroxy phenylacetic acid, right? Whereas it can also be oxidized to catechol O-methyl transferase. With this enzyme, dopamine is converted to 3-methoxytyramine. This 3-methoxytyramine needs monoamine oxidase B, whereas 3,4-dihydroxy phenylacetic acid needs COMT, that is catechol O-methyl transferase, and at the end it is converted to homovanillic acid. Right, so this monoamine B oxidase inhibitors, so these will inhibit this enzyme, and thus there is no conversion of dopamine. This occurs in brain, remember, centrally. This is called as central dopamine metabolism, because we'll forget things, right? So this monoamine oxidase B inhibitors include two: selagelin and rasagelin. So what does this help? How does this help? So selagelin and rasagelin, these are used in early disease as monotherapy because they reduce off time. In early disease, they are used as monotherapy. They reduce off time if used with levodopa. If used with the levodopa, they reduce the off time. Right? So, and there is one more thing. It reduces off time in levodopa, but it increases dyskinesia in levodopa treated patients. So for that, to avoid this, you will have to titrate the levodopa dose and to adjust it. So what are the side effects of monoamine oxidase B inhibitors? The one side effect is these monoamine oxidase B inhibitors, these will inhibit monoamine oxidase A isoform. Okay, normally what happens? Monoamine A isomer, this converts tyramine in gut to soluble excretable metabolite. So this is excreted. But whenever this monoamine A isoform is inhibited, then there is tyramine in the gut. It causes an effect called as cheese effect, which is precipitated by cheese, red wine and aged meats. Right? So this is the major side effect which one should remember. That is cheese effect. Right? So this is about monoamine oxidase B inhibitors. But this selagelin and resergelin which we use, so these have no cheese effect. Why? Because of low therapeutic dose. We don't whenever there is increased doses, only and only then this reaction is seen. Okay. Then one more important thing with monoamine oxidase B inhibitor is there is MPTP toxicity which is associated with Parkinson's disease. If you remember the etiology class, I said in the drugs there may be heavy metals and also MPTP toxicity that can cause Parkinson's disease. This MPTP toxicity, this is prevented by co-administration of monoamine oxidase B inhibitors. When this monoamine oxidase B inhibitors are given to these patients, this will block conversion of this mono MPTP to pyridinium ion. This is MPP plus, which is toxic to the body, toxic leading to Parkinson's disease. So these will also inhibit this toxicity, right? And this monoamine oxidase B also inhibit oxidative stress, thus providing anti-apoptotic effects. Okay, so you can use this monoamine oxidase B inhibitors a lot. So now the next drug which can be used is COMT inhibitors. COMT is catechol O-methyl transferase inhibitors. So if you see dopamine, centrally it is converted to by COMT, and monoamine oxidase it is converted to two metabolites, and finally with monoamine oxidase and COMT it is again converted to homovanillic acid, right? So at the end, so these inhibitors will block this COMT. So what are those drugs? Those drugs include tolcapone and entacapone. Okay. I'm really sorry. Yeah. So this is tolcapone and entacapone. So there, what does these do? So as I have said, these tolcopone and entacopone, these will inhibit catechol O methyl transferase enzyme, and thus inhibits destruction of dopamine, regeneration of dopamine, right? Now there is combination tablet. So this is available as a combination tablet that includes levodopa. So for always, if you want the good efficacy of levodopa, it should always be combined with carbidopa, and we can give entacopone along with it. Okay, and as I have said, this, I'm really sorry. Now today it's not good at all. Yeah, as I have said, this dopamine is metabolized like this, and even the levodopa, even this is metabolized to methyl dopa by COMT. So these COMT inhibitors also inhibit the metabolism of levodopa. So if you give levodopa along with COMT inhibitors, if you give COMT inhibitors along with levodopa, so the action of levodopa is increased, right? So this is the tablet which is always given. This is really good. What are the side effects? Side effects, one, dopaminergic side effects. The dopaminergic side effects include, as we have seen lots of times, nausea, vomiting, and increased dyskinesias. These are seen. And if you see with tolcopone, there is one more side effect, which is diarrhea. Diarrhea is seen along with tolcopone. And then at some places, even fatal liver toxicity is seen. So both tolcopone and entacapone, in this both these have both these metabolite is accumulated. Whenever there is accumulation of their metabolite, this accumulation, this causes change in color of urine. So this causes discoloration of urine, right? So this tolcopone, whenever COMT inhibitors are combined with levodopa, it is said that it provides a continuous delivery of levodopa, because if you see, levodopa is always given in intermittent and pulsatile form because of this effect, because the drug is given and then it increases, and then once it degrades, it decreases, the dose decreases. So there is pulsatile delivery. But here, once levodopa is combined with COMT inhibitors, there is continuous delivery of levodopa, thus decreasing dyskinesias. So this is one of the reasons why dyskinesia is decreased when COMT, that is a catechol O methyl transferase drug, is used along with levodopa, right? So now let us learn about the other medical therapies which are available. So other medical therapies. Other medical therapies include, number 1, centrally acting anticholinergics. The centrally acting anticholinergic drugs include, number 1, trihexyphenidyl and benztrophin. So what is their effect? They will inhibit tremors. So these are they have limited use. They are not much used. They are used limitedly in elderly. So what is their side effect? The side effect include urinary dysfunction because of their anticholinergic effects, dysfunction, and there is glaucoma and cognitive impairment. Right? The second drug which can be used is NMDA receptor antagonist, which is amantadine. Though it is a drug which is introduced as an antiviral agent, it has anti-Parkinsonism effect, so it is used for mild disease. It is used in mild disease, and it is used as anti-dyskinetic agent, so it decreases dyskinesia. So it is used as an anti-dyskinetic agent in advanced disease. Right? So this is the other drug which is used. But what are the side effects of the semantide? The side effect include libido reticularis, weight gain, impaired cognitive function. Right? So these are the side effects. Now, neuroprotection. There are many therapeutic agents which are available for treatment of Parkinson's disease, but still there is disability because the disease progression is intense, and these agents will not help in disease progression. Though they help in disease progression, they cause some other side effects. So it has been proposed that several trials are being made for finding a neuroprotective agent. So in those trials, rasagiline is one drug which has good results. Selagiline also, and coenzyme Q10, and sometimes pramipexole and ropinirole. In all these, there is positive result in clinical trials. But still, it is not possible to determine if these positive effects are due to neuroprotection or due to its effect on dopamine, pharmacological effect. So, these should be considered in slow disease progression case. Next, surgical treatment. These have been started. We have started using these surgical treatment for more than a century. So we have started using these surgical treatments for more than a century. So here in surgical treatment, generally first we have to think about pallidotomy. So this pallidotomy improves dyskinesia. To improve dyskinesia, we can do pallidotomy. And then right now there is one more procedure which is being used, which is deep brain stimulation. Here you place an electrode in the targeted area. Place an electrode in targeted area, whether in cortex or in the occipital lobe or any area where it is targeted. We'll keep an electrode, and then you connect this electrode to a stimulator. Connect it to a stimulator which is inserted subcutaneously in the chest wall. Now it stimulates the effects of the lesion. thus decreases the lesion. So where do you keep? So for example, just I'll take a hypothetical situation and I'll show you how we keep the electrode. So this is the brain, right? You keep an electrode somewhere here, and then the person will have, this is what he has, and then you'll keep the stimulator on the chest subcutaneously. Here you keep a stimulator and here you keep an electrode, and you will stimulate here. Once you stimulate here, the impulses pass like this to the electrodes, and here it stimulates the lesion, right? This deep brain stimulator in the Parkinson's disease, it targets deep brain stimulator. It targets majorly substantia nigra or globus pallidus. So this is what it mainly looks at. So it has good results. It improves dyskinesia, and also it improves off effects also. So it is mainly indicated in those patients who have levodopa induced motor complications. Used if levodopa induced motor complications. Okay. So now, what are the side effects with respect to surgical procedure? The side effects include number one, for surgery, for all the surgery, there are side effects of hemorrhage, infarction and infection. And for deep brain stimulation system, there is infection. Sometimes the leads which we keep, they may break. Sometimes there may be displacement of leads, which is lead displacement, and there may be skin ulceration sometimes. And there are side effects for stimulation. These side effects include ocular and speech abnormalities. There may be muscle twitches because of the stimulation, and there may be paresthesias, depression, and rarely suicidal tendencies may be seen. So these are the surgical therapies which are available. There are even still experimental surgical therapies which are still on trials. They include, I'm just naming them. One is cell-based therapies. Here we can transplant the fetal nigral cells, fetal nigral dopamine cells, or dopamine neurons from stem cells. And then you can do gene therapy and also trophic factors. Right? How do you do all that? These are not still came to use, so I don't want to discuss them in brief. I don't want to discuss them elaborately. So now, what are the treatment options which are available for non-motor and non-dopaminergic symptoms? Right now we have dealt everything, all the drugs which affect dopamine. But in Parkinson's disease, as I have said in the beginning, all the symptoms are not just due to dopamine. There are some symptoms which occur due to serotonin receptors, due to cholinergic receptors, and due to noradrenaline. So how are you going to treat them? So one, this is treatment of non-motor and non-dopaminergic features. Futures. So many Parkinson patients suffer from depression, which is always undiagnosed and undertreated. So always this depression should be treated with antidepressants. Theoretically, serotonin syndromes are the major concern. So these serotonin syndromes are concerned theoretically, but rarely they are encountered. And these serotonin symptoms are treated by selective serotonin reuptake inhibitors, that is SSRIs, and also monoamine oxidase B inhibitors, that is MAOB, right? And sometimes the patient has anxiety, so this anxiety is treated with benzodiazepines. And then there may be hallucinations can occur. These hallucinations can be visual, formed, threatening, and sometimes there may be psychosis. So all these can be treated by antipsychotics, that is neuroleptics can be used. So this neuroleptic which is used is clozapine, right? Then there is dementia which is associated with Parkinson's disease. So this dementia in Parkinson's disease is also seen. And then so in such situation, we can use drugs of dementia like rivastigmine or donepezil. You can also use memantine for autonomic disturbances. You will have to add salt to diet and elevate head of bed. Why? This is to prevent sodium natriuresis. And there is also for these, and in autonomic disturbances, there is orthostatic hypotension. So for this orthostatic hypotension, we add salt to diet, and we also elevate head end of the bed. And in some cases, we can also give hydrocortisol or midodrine, right? In orthostatic hypertension 1, and also sexual disturbance can also occur due to autonomic disturbances. In sexual dysfunction, you can use drugs like sildenafil or tadalafil. And if there is some bladder incontinence, if for treating it, you can use cholinergic agent like ditropan. If there is constipation, then you can use mild laxatives. If there are sleep disorders, you can treat them with clonazepam. So clonazepam. So all these are the drugs which are used for other symptoms, that is non-motor and non-dopaminergic symptoms seen in Parkinson's disease. So now let us learn about the non-pharmacological therapy. So all these are the drugs. So what are the non-pharmacological therapy which is seen? Pharmacological therapy. These include, number 1, gait. For gait disturbances, you can give them canes and walkers. So second, there are many freezing episodes. These freezing episodes occurs, that is, they freeze for seconds to minutes. So this freezing episode causes falling frequently. So this freezing episodes can be treated by dopaminergic therapies, but along with that, we will have to ask them to march in a place, sing a song, or go in a line to decrease these freezing episodes. And third, you have to ask them to exercise with full range of active and passive movements. So this is important, right? So these are the different pharmacological therapy. You have to give education about these things and about the disease, and also some education which is assisting the financial plan, and also home safety should be taught, and social services should be the awareness about social services should be given, and caregivers should never be neglected, because caregivers are really important in Parkinson's disease. And now coming to the next one, which is current management. How do you manage it now? Now there are two major approaches. The first approach is giving levodopa, is to begin with levodopa immediately in low doses. This is given for younger patients, and it reduces risk of motor complications. And second approach, giving an MAOB, that is monoamine oxidase B inhibitor or dopamine agonist initially, and then reserve levodopa for later stages. So this is the treatment options which are available for for Parkinson's disease. Thank you guys for watching my lecture. If you feel something is inadequate in this lecture, or I can add something to this lecture, please comment it in the comment section. Thank you for watching my lecture. If you have any doubts, please comment it in the comment section. Thank you guys. Thank you.